today. Just a reminder, before I introduce our speaker today, I will ask you to please enter your questions in the chat at the end of the presentation. And please let us know whether you were present at today's rounds by filling out a brief survey that will be sent immediately after the medical grant rounds. So it's a great pleasure to introduce our speaker today, one of our own, Mohan Radhakrishna, who is with us today. Just a little bit for those of you who don't know him. Dr. Radhakrishna completed a bachelor's degree in neurobiology at McGill, and then he went on to do medical school at Queen's University. He completed residency in physiatry at the University of Alberta and fellowship at the University of Manitoba in musculoskeletal medicine. He is a past president of the Canadian Association of Physical Medicine and Rehabilitation, and he is currently on the specialty committee of the Royal College of Physicians and Surgeons of Canada, who have granted him founder status for his work in developing the pain medicine subspecialty. And I do hope we hear a little bit more about that today. Congratulations on that. So without further ado, I would like our speaker, I give you the podium, Mohan. Go ahead.
Okay, thank you, Nadia. Thank you, the Department of Medicine, for inviting me to speak to you today. This is a Zoom talk, so you have the advantage of not having to travel to come to hear the talk. And the other advantage, you can get up and stretch a little bit during the talk. I think it's very good for those of you with back problems or not. So practice some prevention. So what we're going to do is we're going to talk a little bit about where back pain comes from. And I'll tell you right off the bat, if I knew the answer, accepting the Nobel Prize would not be sitting here at the MGH, right? That's an impossible question, but we'll talk a little bit about it because I think it's very interesting. We'll talk about how to manage it and a bit on where you should refer your patients at the end. So let's see here. I have no conflicts of interest. So what are the objectives? I think number one, I'd like you to be able to name the most frequent cause of chronic low back pain based on the age of your patient. So I have some idea about epidemiology. Number two, I think I'm interested in phenomenon of degenerative disc changes. And I use the word changes, not degenerative disc disease, as you might see in a radiology report. It's not a disease any more than I have degenerative hair changes. Disease or degenerative skin disease, right? So those are the aging phenomenon that we all get. And then we'll talk about some new therapies for discogenic low back pain. So epidemiology. So a couple of years ago in Lancet, they had a global pandemic, if you like, is what they called it, of low back pain. And they looked at how low back pain was viewed in different areas of the world. And the stats they have are very similar to the stats I've seen in North America. And in fact, they're not that different than when I give talks in person. So I give this talk to a group of medical students, and I see how many of you have back pain right now. Roughly 5 to 10% say yes. When I give the same talk to a group of physicians who are, of course, older, that percentage goes up substantially. And so roughly they say at any point in time, they say roughly 18%, so 1 in 5 people will have low back pain. In a month, roughly 1/3 of the population. In a lifetime, 80%. And I would say the other 20% just forgot because it's pretty much impossible not to have low back pain at some point during your life, whether you're carrying heavy loads up the Himalayas or not. Why does that matter? Not only is it highly prevalent, it's highly costly. So this slide comes out of JAMA 2020, looking at healthcare costs in the US. You're not meant to be able to read all the numbers. So I just want to focus on the left of the screen. You see that low back and neck pain was the #1 most costly thing. When you look at public insurance, private insurance, and out-of-pocket payments that people make. Other MSK disorders was #2, diabetes #3. So it's very expensive. It costs us a lot of money. And don't forget that when you're paying for the low back pain treatment, you're not paying for something else. And #3, this is at the Olympics time, low back pain is the #1 gold medal winning number of years of disability. So it's a huge problem. And yet, despite that, as physicians, sometimes we're a bit unhappy, right? We have this kind of dumbfounded look when a patient comes and our head spins when trying to figure out how to deal with this problem. And that's because the patient doesn't just come with low back pain. They come in with other baggage that surrounds them that led to their perception of the pain. And being aware of that perception of how people perceive pain is very important in trying to manage it. So if you go back to the 1980s, 1990s, this is how we taught medical students, and we still teach them a lot in the same way today. That is, when you see a patient with low back pain, first, screen for what the so-called red flags. So those are sort of what we call serious conditions. So I put them separate here on this graph. So things like fractures, cancer, cauda equina, infection, and I've sort of thrown in the rheumatological causes of seronegative spinal arthropathy in there. So we tell the students and the residents, do this, and then everything else, well, that's just mechanical low back pain. And the problem is, of course, is that everything else is probably more than 95% of the patients. So you can tell patients, I know you don't have, but then you're stuck as saying, what do you have? And that was very tough for patients and physicians alike, actually. And we also created some artificial constructs where we sort of said, okay, you have acute low back pain, and that meant pain less than 1 month. You have subacute, which means, depending on the publication, between 1 and 3 months or 1 and 6 months, and chronic back pain is more than that. But that isn't really how it works in real life, right? So in real life, back pain is recurrent. It's not just acute, subacute, or chronic. We're taught that most improve within 1 month, and that's true, but most still have some symptoms at 1 year. It doesn't usually go away completely, and it usually fluctuates in intensity. So what does that mean? It means it's very hard to do a study because people are going to be changing in terms of their level of pain and their level of disability. And what usually happens, not only in the context of a study, but in clinical practice, is that when does somebody seek treatment? Well, when they're at their worst. And it doesn't really matter at that point what you're doing. They might be regressing to the mean anyway and will improve regardless of what you do. So it makes it very tough to do studies. How do we start? Well, we always start the same way with any problem, with the history. And I talked a little bit about screening for red flags, but it's much more than that. I think when you see a patient with low back pain for the first time, you need to create an alliance with them because their risk for disability is very proportional to their feelings about pain in general and how they manage. And a lot of that can come from the message that you send them. So often the physician in the emergency department who tells them, oh, sorry, you have arthritis or you have degenerative disc disease is in fact doing them a disservice because often the patient there walks away with that idea that they're going to be disabled and they don't have the chance to go back, of course, to that physician and see them again to get more information. The other thing that you can do when you dig the history is you can screen for what we call yellow flags. So red flags everyone knows about, right? Those are risk factors for serious causes of back pain. Yellow flags are causes for disability. So roughly 7% of people with chronic back pain develop disability from it. And it's pretty hard to ask somebody, so, do you think you have yellow flags? And what we end up asking them is questions about their psychosocial situation, whether they have a history of mental health disorder. And you can also listen for things they say. So we'll talk about that in a second. There are some historical features that can predict discogenic pain. And discogenic pain is what we'll talk about later on. And that tends to happen more in younger people. And one of the things you might hear from your patients is that they have recurrent attacks of pain. So they'll say, yeah, I might see a patient who's 40. They'll say, when I was 25, I had an attack. I was really bedridden for a few days, and then I was up again, back to normal life, had another one at 30, and now I'm having them over and over again. It's a fairly common story you hear when there's discogenic pain. On the other hand, when there's yellow flags, there are things that people say, and they say stuff like this: I do not want to do too much. So that means like I'm sort of scared, I'm a bit worried. If I do too much, I'll have more pain. So that's a bit of what we call kinesiophobia. They might say, I wonder if I can ever return to work. So that's an example of what we call catastrophization. So they have this idea that whatever they have, it's really, really bad. When they start talking like that, it's usually a bad sign that they're for their overall prognosis. Another classical one is, I do not want to pay for it tomorrow. So I tell the physio, I do what you want me to do, physio, but I don't want to pay for it tomorrow, so I'm not going to do it. And then my other favorite one is I have a high pain tolerance. So they'll say, she's doing some encore, doc. They say that, or I have a high pain tolerance. I always think, well, if you have a high pain tolerance, really, really high, how do you know? We don't have a way of measuring that, and you probably wouldn't be seeing me if you did. So when people say that kind of stuff, start thinking about yellow flags. Physical examination is not very good at determining the source of the pain. Now, of course, you want to do it. You want to make sure they don't have some other medical problem that's not musculoskeletal. You want to make sure that they don't have a rheumatologic problem or one of the red flag conditions. And I think it also lets you see how the patient moves, how kinesiophobic are they, How strong are they? So this is very important to do, but you should understand that there's no real great maneuver that guarantees the patient has pain from that source. Maybe the possible exception of that is sacral leg joint pain if they have enough positive maneuvers. But really, that's about it. And don't forget about the patient's body habitus and weight. And so their general physical health has a clear impact on back pain. What about investigations? So everyone loves MRIs. This is a composite table taken of a study of more than 3,000 patients, stratifying by age and imaging findings. What I've done is I've taken two columns out of that to make it easier for you to read. So what you have here on this column here is people who are 40. On the right, people who are 70. And if you look for things you find in asymptomatic people, so good old disc degeneration, so degenerative disc disease, the time you're 40, odds are you probably already have it. And if you're 90, it's pretty much guaranteed. Something like, for example, though, an annular fissure in a disc, less common in an asymptomatic person, only about 1 in 4, 1 in 5, regardless of your age. So some findings are therefore more predictable of perhaps symptomatic people than others, and others are just very, very common. Now, what about stenosis? Because I get a lot of people saying, no, but I have stenosis on my MRI, not just arthritis. Here's a study they did out of Japan, published in 2013. They have a lot of money in Japan. They took almost 1,000 people and MRI'd them all with no pain and saw what do they have on their findings. And this is a graph from that. And without looking at all of the different schemas, if we look at, say, the top left corner and take, say, a 50-year-old male looking at central stenosis, roughly 1 in 5 people who are 50 have severe spinal stenosis. When you tack on the moderate level, you get up to about 60%. So in other words, stenosis is very common too. So MRI does not really help us very much know where pain is coming from because everybody has these changes. That's what makes it so difficult to manage. And similar to the MRI, CT doesn't help us anymore, and neither do X-rays when you're talking about chronic back pain changes. So extra, what's happened recently in all this? Well, the International Association of Study of Pain has tried to try to redefine types of pain. So what they did, we sort of always talk about nociceptive pain, so pain receptors pain. So in other words, if I whack my elbow, I'm getting pain from nociception. We know about neuropathic pain. So classic example is diabetic polyneuropathy with burning in the feet. And now they have this new idea called nociplastic pain. And really the idea of plastic brings about the idea of plasticity in our central nervous system and how that can change and affect a person's perception of pain. So, this is sort of a long definition, but basically it's pain arising from altered nociception despite no clear evidence of actual or threatened tissue damage, causing the activation of peripheral nociceptors or evidence for lesion, for disease or a lesion of the somatosensory system. So another way to think about it is it's like an altered function of the peripheral nervous system and the central nervous system that causes increased sensitivity to pain. So this is a diagram out of Lancet, and without going through all the details of it, the idea is that at the peripheral level, there is changes of peripheral sensitization with expansion of receptive fields. At the spinal mechanism level, there can be some spinal cord reorganization and regional clustering of signals from different loci. And even at the brain level, there are changes, so hyperresponsiveness to pain stimuli that they can have. And these combination together affects how the patient presents. So the patient might have not just pain, but other problems like sleep disturbances, cognitive disturbances, hypersensitivity, and anxiety and depression mood. So the way I think about it is how you go a bit how you look through this flow chart. This is published a few months ago in pain. The idea is that you have a patient who has pain for more than 3 months, and it's regional rather than discrete. In other words, they don't say my back hurts here and point to one point. They sort of globalize where their back pain is. You think it's not entirely nociceptive or neuropathic, and of course I accept that's a judgment call. And then you see, did they have some kind of hypersensitivity? So do they have what they call static mechanical allodynia? So in other words, pushing on it hurts. Dynamic means when they move it hurts. Sensitivity to hot or cold, or sort of what they call painful after sensation reported after the assessment. So when they have those kind of things, start thinking maybe this is actually nociplastic pain rather than a focal back pathology. Then you add to that, down here, this history of hypersensitivity and comorbidities. So they have a history of pain elsewhere, either to touch or to pressure, to movement. And do they have these other problems that I mentioned before, the fatigue, these sleep disturbances, hypersensitivity to sound or noise, or cognitive problems, the so-called brain fog? So when you hear that, you're thinking maybe it's probably nociplastic pain, not just back pain alone. So when I hear this, the way I look at this to people is that really it's low back pain with a fibromyalgia type construct, where we all know that people who have fibromyalgia present with these certain fibrofog type symptoms, the poor sleep and everything else. So you imagine the low back pain with these fibro plus symptoms is probably not a focal back pain problem alone. It's more of a nociplastic pain problem. So if we think of it that way, this large circle of low back pain now has one part that's non-specific, which I would call the nociplastic pain, but part of it could be maybe specific. And I made this roughly 1/4. There's no statistic on this, but some part of it is going to be nociplastic, and some part of it we could perhaps define better. And so another way to look at it is you have your red flags here on one side, you have your yellow flags, which I think will often line up quite well with the nociplastic group, although there's no study about that. That's my personal opinion, with, of course, some overlap with some nociplastic people who don't have yellow flags and some people that will have yellow flags who don't have nociplastic pain. But there's some group who can maybe do a little bit better in terms of defining where it could maybe come from. So guidelines. So how to treat low back pain. There are many guidelines out there. This is a systemic review of the guidelines. So there are about 15 world guidelines out there, and they're pretty much the same if you read them through. Sometimes there's some small differences that often related to physical activity, less more related to culture than anything else. And the big problem with these guidelines is that they lump everyone together. And I'll give you some example of why that can be difficult to sort out. But when you lump everyone together, it can be often very hard to find answers looking for significance when you're doing clinical trials. So I'm not going to go through the guidelines in tons of detail. I'll refer you to a couple. So Top Alberta Doctors is a nice one from Canada. So TOP stands for Towards Optimized Practice. And so this is online, it's free. They have it sort of divided up into sort of not length of time the patients have had their symptoms. And it's often the same basic things, right? We know that the most important part for back pain, in fact, is not pills. So pills are just cover symptoms, they don't cure anything. So the most important part for managing back pain is changes in behavior. So it's activity, pushing active physiotherapy, active lifestyles, proper sleep, judicious use of anti-inflammatories, sometimes other analgesics, not overdoing too much on the opioids, for example. The other one that you might see a lot, published in the Annals of Internal Medicine, is the ACP guidelines. Again, fairly similar. The problem always with these guidelines, as I said before, is trying to find good studies to support them. And that's often hard because patients are often lumped together in huge groups. So in other words, can we try to do it better with these guidelines by being a bit more specific? So I'll give you an example of why they're a bit hard. So if I told you antibiotics don't work for cough, you might tell me, okay, this guy's a physiatrist, doesn't know anything about coughs, but he's probably right that most coughs come from viruses. And so probably antibiotics don't work for coughs, but we know that some coughs are bacterial in origin. So maybe that question's a bit rough, right? You're getting a rough treatment. Antibiotics is not a very clear treatment, and a symptom, cough. So if I change that into low back pain parlance, and I said, physiotherapy doesn't work for back pain, the physiotherapist would say, well, hang on, physiotherapy is a profession, not a treatment. So you should be being a bit more specific about what you're talking about. And back pain is a symptom, not a diagnosis. So, but unfortunately, that's what happens when we do a lot of these clinical practice guidelines, for example. They sort of take that paradigm. If you try to be more specific, so antibiotics don't work for pneumonia. So you could say, well, okay, now you're being a bit more defined, but we still aren't talking about what the antibiotic is. We haven't talked about how long we're giving it for or the dose. And we haven't talked about what kind of pneumonia. So we have to be much more specific. So, for example, amoxicillin works for outpatient management of community-acquired bacterial pneumonia in healthy adults. And when you get to that level, which is where we are at for other medical conditions, we need to get to that level for back pain. And that's going to take a very long time to get that far because of the difficulty it is in defining the treatment and in defining the source. So it's a bit like the classic fable out of the Indian subcontinent when everyone's trying to examine this elephant, but we're all blind, right? So the man on the right here thinks the elephant is like a wall. The man down here thinks the elephant is like a tree trunk. The one pushing the tusk feels the elephant is like a spear. We don't have a good sense of what low back pain is either. And so when we're looking at this from a study point of view, that makes it very difficult. And so one thing to be aware of is how do they define success in low back pain trials? And so, they look at different ways of trying to assess this. So a classic one is low back pain trial, we want less pain. So usually they define the minimal clinically important difference as 2 points on a VAS score, a visual analog score, as being success. But that's minimal. If I told a patient I can get your pain from 8 to 6, no one's going to be jumping up and down thanking me for that. That's not a massive improvement. We can look at less disability. So most studies, you want to have less disability, and they'll measure that usually with the Oswestry disability inventory or the Rowan-Morris are kind of two classic questionnaires used for low back pain. They can look at quality of life. So the SF-36 can be used for that as an example. If there's many other scales, of course. Do you measure less medication use? Now you're getting into things a little bit further away from your treatment, where people might be taking medications for other reasons than purely for the back pain. But obviously, if you're taking less pills, that would be a good sign. Have they gone back to work? Often return to normal function, whether that's work or volunteering or getting all the normal activities of daily living, is a key endpoint, but often not recorded in trials. So I'm going to switch gears a little bit and try to help you decide where back pain comes from based on age. And I picked these pictures out of a publication by Michael DePalma out of Philadelphia, published about 10 years ago. But there are other studies that were done before this as well with similar findings, although what he did was kind of nice in that he stratified it by age in a very, very categorical way. And so if you look at, say, the top right, where they have FJA, means facet joint arthritis as the cause of the pain. So we took roughly 200 people who had chronic low back pain, not responsive after a few months to traditional exercises and physiotherapy and the usual medications. And what they did was they selectively froze different parts of that person's back to try to see if they could identify a place where the person would say, my pain is gone. And so they did that on a number of people. And you would see that, for example, if you're 60 years old, then you have roughly a 50% chance of having facet joint arthropathy as the cause of your pain. If you are 25 years old, right on the bottom left of that graph, the odds are very, very low, right? It's almost like less than 10% that they have facet joint arthropathy as the cause of their pain. That shouldn't surprise you, right? If you see someone with knee pain and they're 25, you don't think they have osteoarthritis. That'd be very unlikely. But somehow with the back, because we see things on imaging and we have no easy answer to give the patient, they get told they have arthritis as the cause of their pain, often at a young age when it doesn't actually make sense. On the other hand, if you look at this top left, you have a young person, let's say someone who's 30, the odds of them having disc pain was fairly high, right? Not 100%, but getting up to the 90% range as a cause of the chronic back pain. And so, that's an interesting one because of course, these are the people who are in the age of working and who end up being disabled sometimes from these symptoms. So I think if you keep this in mind, you see an older person with back pain, you think likely arthritis, younger person, likely disc. The problem is not a good lot of treatments for disc pain. And we'll talk about that a little bit later. So in other words, what is the cure for discogenic pain? And so I sort of call this, the search for the holy grail in low back pain is trying to find a cure for discogenic pain. And so, if you go back to the early, 1900s, people thought that, low back pain was likely because of facet joint arthritis. You have arthritis, that's the cause of your pain. If you have rheumatism, that's the cause of your pain. But then Mixter and Barr came along. And so Mixter was a neurosurgeon out of Mass General, and Barr was an orthopedic surgeon. And, they had done some work where they had this idea that when people had paraplegia or sciatica from a disc herniation, the thought at the time was that they had some kind of tumor, a chondroma coming out, pushing on the nerve in question. And then they found out by resecting this so-called tumor, and then looking at it pathologically, they realized it was the same as the disc. And then that's where it got the idea going that the disc can be the cause of the pain by itself, and not just in causes of sciatica. So what do we have when we look at a disc? So let's go back to a bit of basic pathology. We know the disc is made of two things. You have the annulus fibrosus, which is made up of different lamina, different levels, with different directions of the collagen to allow for different movement of the spine. Inside this is the nucleus pulposus, which is holding a lot of water, and in doing so, that allows the spine to absorb compressive forces. And over time, that nucleus pulposus, which has originally come from the notochord in embryologic development, dries out and changes. I'll show you some pictures of that afterwards. And then the third thing there is the cartilage end plate. So the idea is that the cartilage end plate is, if you like, the buffer between the disc and the vertebral body, and allows for diffusion of nutrients across into the disc, because the disc is very avascular structure. The disc usually also has little spinal innervation. So the sinovertebral nerve innervates the outer part of the annulus fibrosus, but not more. So usually there's quite limited innervation of the disc in a normal person. So what happens as we age and as our bodies change? Well, there are numerous factors affecting that. There's genetics, there's aging, there's smoking, which affects the circulation to the disc, and there's mechanics that I'll talk about in a second. But this combination of factors leads over time to decreased nutrient availability, along with cell death and apoptosis, in other words, leading to structural changes in the disc. With that, you get neoinnervation, in other words, nerve growing into the disc structure, leading to back pain. And the other thing that also happens is as your disc gets narrower, that loads the facet joints in the back more, and you can get facet joint pain and facet degeneration as well. So it's kind of a catch-22 as this happens. So what are the mechanics? Well, the mechanics are multiple things. One of them is just compression. So compression directly on the disc can lead to an end plate fracture. But the one you see a lot more clinically is patients who talk about reaching forward to pick up something or bending forward and twisting. So in other words, torsion and bending can tear the annulus. And that is something that we hear clinically all the time. And bending forward stretches the annulus. So you imagine if you bend forward, then the posterior part of the disc, which is at the back, will get stretched. And of course, if it gets stretched and breaks, where's that it's going to come out? It's going to come out posteriorly, and therefore potentially cause radiculopathy. So a lot of our activities in life involve bending forward. And most of the time, if you ask patients, they're not lifting a piano when they develop low back pain. It can often be a benign thing like picking up soap off the bottom of the shower or tying their shoes. So another thing I want to show you, this is a a diagram out of an old publication by Jacobson back in the 70s, where they stuck pressure transducers into people's discs and put them in different positions to see what kind of pressures they would measure. And he normalized that to 100 for the standing position. So if you look at this where this person is standing, their pressure is 100. When someone is sitting, that pressure is 140. In other words, you have more pressure in your disc when you sit than when you're standing. And that's felt because when we sit down, our spines flex. And so it's kind of funny, when you have someone who has back pain and they get put on light duties doing desk work, if it's from the disc, but maybe not, it might not be such a good thing to do. You see if they're, bending forward and carrying a weight, that can increase discal pressure quite a bit. The other thing that you can use out of interest on the right side of this graph is positions with exercises. So the one I like to show people a lot is the idea of doing this classic sit-up. When you have pressure going up to 210 with doing a sit-up, it's actually probably a little bit rough on someone with back problems. And what's recommended more is you do just a gentle shoulder curl, lifting your shoulders a few inches off the table, not more than that. I think I'll tell you, those of you who are exercisers, is as we get, when we sleep at night, our discs become more hydrated. In other words, they get more water inside. And so a good time to do exercises like that would put pressure on the disc, like sit-ups, for example, is not first thing in the morning, because you're most likely to have a disc herniation from doing that. Waiting an hour or so to let that pressure equilibrate would make more sense for you. Okay. So let's do a little case. And this is a real case. See what you think. This is a 35-year-old banker, so a young person, no past medical history, so totally healthy. Has low back pain only, no sciatica, right? So we're talking about back pain patients only today, not radicular patients. And this has been there for 8 years, which if you're 35 years old, is like forever. So he has this pain. He's tried physiotherapy multiple times. He took so many anti-inflammatories, he got an ulcer and had to be scoped for that. He had an MRI scan, you see that this scan shows at L5S1, the disc is a little bit blacker than the other ones. So in other words, there is less fluid in the nucleus on this T2 image. So in this image, CSF is white, so fluid is white. So there's less fluid in his nucleus, and his disc is narrower. So he had this probably discogenic pain given his age, right? But he went on to have a lumbar radiofrequency neurotomy with a few weeks of pain relief. So you're going to ask me, well, what is that? And I'll show you what that is. But I'll tell you that that's directed towards pain from the lumbar facet joints. So if you think back to what I showed you before, you might question that. So what do we do? When we do this neurotomy, first we do what's called medial branch blocks. So we put some needles down and freeze the nerves that innervate the facet joint. The idea being is if we freeze the nerve and your pain is coming from that spot, your pain should go away. Same idea, you go to the dentist freezes the wrong nerve, your tooth still hurts. On the other hand, if we freeze the right one, then your pain should go away. So, he underwent this medial branch blocks. And then if the person seems to respond to that, in other words, their pain improves substantially, let's say it goes from 7 till 2, for example, then they might be a candidate for what we call the neurotomy. So what we do with that is we, under X-ray guidance, we put down a special needle. So these needles here on the bottom right are special because they have a wire, if you like, that goes into it that can plug into this machine here on the left that heats up the tip. The tip of the needle is uninsulated and it rises up to 80 degrees Celsius and cauterizes the area in question, therefore destroying the small nerve that innervates the facet joint. So we had this done. It worked only for a few weeks. Well, it shouldn't surprise you, right? Because this guy is a young guy, he's 35 years old. The chance that he had facet joint pain in the first place is, very low, maybe 15%. And so I would submit that he probably was having a placebo response, probably more than anything, in his response to these initial treatments. So you have to always go back to prevalence. So just like you wouldn't treat a 25-year-old with chest pain the same way as a 7-year-old with chest pain, And so back pain is a bit the same thing. You have to get a sense of what's the prevalence, and that helps you decide what treatment you should provide. So what's the pretest probability, in other words? And then you would multiply that by a likelihood ratio of any treatment that you're offering to come up with the idea that whether it's going to help them or not. So I talked to you before about MRI findings in general, and this was an older study. There are some other studies talking about other features that might predict discogenic pain, because focusing just on discogenic pain alone is interesting. And there have been many, many studies about this, with thousands of patients, and I'm not going to go through all the studies and thousands of patients, but the idea is that if you look for certain things, those things being what we call modic 1 and 2 changes. So modic does not stand for something, it's Michael Modic, it's someone's name. So he's a Cleveland clinic radiologist, and a high intensity zone. And if you have those things, the likelihood ratio of them having discogenic pain is roughly 5, roughly. So what does it look like? So on a T2 and T1 sagittal image, you're looking for changes around the disc place itself. So in this one here on the right, T2 image, you see some bright change around the L4-5 disc. And on the T1 image, you see some darker change. See that? That's a good example of a modic type 1 change. A high intensity zone is really what it sounds like. It's a bright light, a real bright spot in the disc that's already black. And that's felt to represent an annular fissure. So that's how they diagnose annular fissures on MRI. So looking for these things will increase the person's chance they have discogenic pain, although it's not 100%. So what are the treatment options for discogenic pain? So traditionally, there's been a ton of treatments. And when you say a ton of treatments, usually it means that nothing works that well. Otherwise, there wouldn't be a ton of treatments. So we have lumbar fusion. We have lumbar disc replacement. And disc replacement was done as a kind of consequence that we know when you have a fusion, you'll get degeneration above and below the fusion. So the idea of disc replacement is that you can get ongoing motion despite having that segment not being painful anymore. The jury is still out whether it works better than fusion or not. Epidural steroid injections are always very popular with very limited evidence. Intradiscal electrotherapy, any intradiscal injection at all, and then a basivertebral nerve ablation. So we'll talk about some of these things. And then on the right side of the screen, you kind of have the wonderful idea of regenerative medicine, where it's just, of course, very, very seductive to both physicians and patients. The idea is that we're not destroying the tissue to take away pain. We're trying to make it grow back. And so everyone loves walking down to the beach, the idea of regenerative medicine. And so we'll talk about that a little bit too. So this is a timeline going across treatments for low back pain over the years. And I'll sort of highlight a couple of things that we McGill were involved in. So in the 1950s, it was like intradiscal steroids. So injecting steroids into discs was a popular thing. And it sort of fell by the wayside as they sort of realized that it was not very effective. And any intradiscal treatment had the risk of causing infection, which is not a good thing. In the 1980s, this is papaya. It's the idea that chymopapine, so a protease enzyme derived from latex from papaya, could be injected into people's discs and make the herniation go away. And basically would dry up the disc, it would dry up the nucleus pulposus completely. And it was quite popular in the 1980s. I've seen some patients who are older who said they've had that in the past. And it's sort of disappeared gradually, partly because there was a high incidence of anaphylaxis with this treatment. So it disappeared. Some people think that there was some pushback from surgeons about trying to get rid of it too to help increase the number of cases for surgery. I'm not sure that was before my time, but at any rate, it was an interesting idea. It doesn't exist anymore. And you'll see there's lots of ideas coming over time. In the 90s, early 2000s, this idea up here came in. And the idea being is that we could coagulate, do a neurotomy of these small nerves at the back of the back for facet joints. Could we do it in the disc as well? And there's lots of different technologies developed for this. I'll just show you an example of one where you would stick a catheter into the disc. remember I told you that when you have back pain and discogenic back pain, you've often got nerves growing into the annulus fibrosus. So you heat up these nerves and coagulate them all, and that would you'd be done. The person's back pain would go away. That was the theory behind it. It didn't really pan out that way. It seemed to help some people some of the time, like a lot of back pain treatments, but didn't really stand the test of time. It was very expensive. So it little fell out of popularity at that time. Down at the bottom here, 2010 is methylene blue. And I'm going to show you the study that was done for that. And we were involved a little bit in a separate study about methylene blue. And in 2013, the idea that maybe infection could be related to back pain came aboard. So methylene blue, so Pangyal. So in 2010, this group out of China published this study, and it was accompanied by an editorial by a pain researcher who's pretty difficult, very, very stringent looking at studies in science. And he titled his editorial "A Cure for Back Pain." So that's extremely very rare. And basically, they had this group of people who had discogenic back pain, 36 in each group, a double-blind, placebo-controlled, randomized controlled trial. You see the methylene blue group had a pain of about 7 before. The saline group, was their placebo group, had a pain also about 7 before. 6 months later, their pain was down to 2.5. This was sustained for 2 years, whereas saline, there was no improvement at all. So that's an incredible response for a pain study. Not only that, they did a SWESTRI, so a disability index, in other words, and there again, the treatment group went from 48 down to 16, while the saline group had no improvement at all. And so, you sort of, in summary, you have a treatment that came out there that's not expensive, that improved their pain score by roughly 52 out of 100 or 5 out of 10, and their SWESTRI score by 35 points, which is a huge improvement for a disability questionnaire. And the funny part about it, though, is that there was absolutely no placebo group improvement, which is kind of odd, right? The reason we do placebos is to see how people will improve with placebo, and they had no improvement at all. So that was the only sort of question that arose. And so what happened with that is that, well, other groups tried to replicate the work, including a study we did here. It was led by Gaurav Gupta, who's a physiatrist here at MUHC and one of our former fellows as well. So we tried to do it, and we did it as a small case series with really no improvement. And at the same time, numerous other groups tried to also replicate it with the same negative results. So methylene blue sort of disappeared from the face of the earth. What about infection? So then someone had this idea: could chronic low back pain be coming from an infection? And that sounds crazy to me. But then I think about years ago in 1982 when they decided that gastric ulcers come from H. pylori. That was crazy too. And they won a Nobel Prize in 2005. So things do change. We have to be open. And so what they had done is someone had done a study where they had taken tissue samples from discs that were operated on for herniated disc reasons, in other words, sciatica reasons or back pain reasons, versus discs that were operated on for non-disc problems. So the one they used was scoliosis. They're trying to straighten someone's back. And they found that roughly half the discs from the back pain group grew Cutibacterium acnes, whereas the scoliosis group grew nothing. So that was the idea that maybe an infection could be the cause. So right away, people were on that.
Everything okay, Mohan?
Yeah, we got cut off there for a second. Can you hear me again?
Yeah, we can hear you again. Thanks.
Okay, very good. So Albert, they did this study, 144 patients with modic 1 changes, pain more than 6, and then they gave them 100 days of antibiotics. This was amoxicillin and clavulate. And the result of that was that people seemed to improve slightly. So you look at the bottom of the screen here, you'll see that their low back pain group went from 6.7 to 3.7 and versus 0 change in the placebo group. And their disability questionnaire also improved. So that was kind of interesting. So what happened, of course, well, we tried to emulate them as well with, again, a small case series with no improvement. And some other groups also tried to emulate them, again, with no significant improvement. There still is some question whether maybe there could be some infection in some patients, but a lot more research needs to be done about this one. Finally, the newest and latest, greatest thing for back pain is the idea that it comes from the end plate itself. So not just the disc, but the end plate itself. So you look at this this diagram, you see that the arteries, entering into the vertebral body arborize significantly, and that's accompanied by nerves that arborize significantly. And maybe these nerves themselves are the cause of the end plate pain, which is why you see these changes of modic type 1 in the end plates. So, of course, they come up with some technology to try to kill those nerves. That seems to be the way we try to do things. So they want to burn the nerve. So you can put this catheter in through the pedicle. It's a bit like doing a vertebroplasty, and then heating up the space. So these are not good studies. They're brand new. I'll just show you one example of a prospective randomized study that is not blinded, and the control group is just usual care. So if you have a trocar stuck in your back or not. But they had 140 patients, 70 in each group, and the ethics board asked them to stop the study because there was such a huge difference. Where after 1 year, the group who got the treatment were improving by 4 points on the VAS, and the Iswestry improved by about 26 points. So quite a significant improvement, but I will tell you, this is not a randomized controlled trial. It's really, and it was funded by the company making the device. So there's a lot of flaws. We won't go into all the flaws, but it is interesting that it seemed to work in the short term. They did offer the treatment to the people who were in the control group at 6 months. So you see here in the middle of the screen, their pain was 6.8. After getting the treatment, they went down to 3.3, and it seemed to be sustained up to 2 years later. So that's interesting. We'll have to wait and see, right? So often in back pain, it's a bit like Charlie Brown in the football, where you're going for it, you think it's going to get it, and then boom, it's gone. So we've had enough treatments over the years where we've had interesting initial trials followed by complete failures over time. Finally, a little bit about regenerative medicine, because you might have heard about it. The idea is that rather than trying to denervate structures or destroy structures, we're trying to regrow things back. So there are two classic ones. One is PRP, stands for platelet-rich plasma, and the other is stem cells. So stem cells have been banned by Health Canada for the use of MSK problems for now. It was just being used almost willy-nilly by people, and I believe it's also banned by the FDA for now. But there were clinics all over the place. I remember seeing ads even in the Montreal Gazette for clinics in Vermont saying, come on down to get an injection of stem cells. But PRP is allowed. So what they do is they take a blood sample from the patient, you spin it down, concentrate growth factors in one part of the aliquot, what you spin down, and then inject that back into the tissue in question. I've done a lot of it in trials of lateral epicondylitis or knee osteoarthritis, for example. But what about for discal pain? This is a meta-analysis published this year, over 3,000 trials. You think they'd find something if they had 3,000 trials, but they still could not find any good results from PRP or stem cells for discogenic pain, showing you just how hard this is and how hard it is to do the research. So in many ways, I look at this new stuff out there as a treatment looking for a disease rather than a disease where we found a good treatment. So just sort of close up, I think when you look at these trials that are very hard to sometimes sift through, looking at a comparison between efficacy in a trial format versus effectiveness in real life, the outcome measure they choose has a big impact on whether they see having to have a positive trial or not. The time frame, we want to make sure that the trial is following people for a long time because of the deviation towards the mean that people have with back pain as it tends to change. The inclusion criteria is very important. Often we have patients with workman's compensation issues, psychological issues, weight issues. In these trials, they try to pick the perfect patient, of course. There's a Hawthorne effect, of course, of being in a trial. And the author effect. There have been studies looking at interventions for back pain, finding that if the primary author was interventionalist, the trial would be positive. If they were not, the trial would be negative. So that obviously has some interesting food for thought, our own personal biases. Don't forget, when you see people with back pain, they have multiple issues. It's not just biophysical. You have to look at their comorbidities, look at their social factors, their psychological factors, and genetic factors that can all contribute to their disability. So when to refer to a physiatrist, I think number one, in the absence of yellow flags, because if people have a lot of yellow flags, it's pretty tough for any individual physician to look after those patients. Often the family doctor is the best, but even for them, working by their office by themselves is very tough. But if looking for exercise advice, medication suggestions, someone who just needs disciplinary management, not a whole team, and or blocks, that'd be reasonable. Low back pain referral schema. I have this slide going from bright yellow on the right to less on the left. Bright yellow means lots of yellow flags. They need a lot of psychological support. The pain clinic is the best place. We have a world-class pain clinic here. The problem, of course, is we have a lot of people waiting to get into it, but people who have a lot of yellow flags would be reasonable for that. People who kind of don't have so much, you might refer them for a block if you have an idea what kind of block you need, or to a physiatrist to help you decide that. And on the left, I put a surgeon as very rare. Our surgeons really, in general, don't operate much on low back pain. There's not much for them to do in the absence of instability. One of the surgeons does disc arthroplasty here, and will sometimes do that on a young active person without yellow flags. But you really have to pick their patients carefully, and they have a long wait list already. So this idea of automatically referring everyone with back pain to a neurosurgeon or orthopedic surgeon really should be quashed. So if you go back to sort of summarize, I want to be able to name the most frequent cause of low back pain based on the age of the patient: young adult, disc; old adult, likely facet or SI joint. Describe the phenomenon of degenerative disc changes. So we've done that. And name some new therapies for discogenic low back pain. The newest one, basivertebral ablation. Will it still be there in 5 years? Wait and see. So thanks for your attention. I think we have time for a few questions.
Thank you so much. Really outstanding lecture, and thanks for reviewing all this important data out there and giving us a little bit of a refresher in our anatomy refresher. Thank you for that. I have a question from Ariel Mendel here. There's a few questions here. Is there any good evidence for weight loss for non-specific lower back pain in overweight patients with or without yellow flags?
Yeah.
Sorry, Mohan, did you hear that?
I sort of caught the first part. Any evidence for weight loss in people who have pain?
Yeah, overweight patients, yes.
Yeah. So I think the answer is no, not as far as I know. I think we know that people who are overweight are going to have increased stress on their discs in the first place. Will changing that weight change their pain over time? No, but we do know that in general activity is good. And I would certainly encourage those people to become more active regardless. And in doing so, that might help them lose some weight. And which part of making them better is the activity or the weight? It's hard to say.
Well, and just to be clear, there's many people on this, more than 100 people on this Zoom. If our patients have lower back pain, where's the first place we refer them? Because sometimes they go to rheum, sometimes they go to neuro, sometimes they can't just come to the pain clinic. So where would be the first place you would refer at the MUHC for lower back pain?
So, at the MUHC, I think the first place they should be followed by actually their family doctor, not by one of the doctors here. That'd be the first place. But if we're assuming they have no family doctor, then likely physiotherapy would be good. Rheum, I don't want to speak for them. I think some rheumatologists have an interest in back pain, but most are more interested in inflammatory back pain. Neurology, I'd say usually no, because it's not usually felt to have a neuropathic problem. So I would not do that. I would not send them for an EMG. There's no value in that. You send them to physiatry, I hesitate to say yes because we're so overwhelmed with referrals. That might be the best place. But I think ideally is that, you probably shouldn't be looking after it here. It's more a family doctor with ideally, I think, physiotherapy. If they don't have physiotherapy coverage, which happens a lot, I try to encourage people rather than seeking health care to live a healthy life. So whether they're doing swimming or yoga or Pilates doesn't necessarily matter. There's no good studies on this, but whether they do something is what really matters.
So Sasha's saying, and not to send, do not send a non-inflammatory back pain to Rheum. Yeah, okay, fair enough. And another question for you, I assume that everyone who is referred has obviously, is coming with pain and chronic type pain or persistent pain, but is there anything that, is there any literature on prevention? So in other words, we see CT scans sometimes that return and there's things on the CT scan on the spine that's read as incidental. Or at the same time, people who have these self-limited repeated episodes every time they do something. Are there kind of anything that would trigger a preventative kind of visit for these? Is there any literature on that?
Yeah, so trying to prevent low back pain. I think a lot of it, these people have recurrent back pain. A lot of it is genetic, partly, and partly it's lifestyle. And so for some people, especially the young ones who have repetitive low back pain, I refer them to a book by Stuart McGill. So Stuart McGill is a engineering emeritus professor from the University of Waterloo, did a lot of basic science research in low back pain. And he has a book called The Back Mechanic, where it does talk a little bit about activities that a person does and movements they do that might provoke symptoms. So often I'll say, have a look at that book and see if you find yourself in there, because people sometimes can't tell you what's causing their problems. But sometimes, in the course of being at home, having the time to think about it longer rather than in a doctor's office, they realize there's certain activities they do that might provoke things. So I think that's reasonable. In general, moving is good. In general, sitting is bad. Smoking, we all know, is bad. So those are good things for prevention as well. The other part I think to keep in mind is that there's low back pain and there's disabled low back pain. So not everyone with back pain is disabled by it. And the ones who are disabled, have an increased incidence of these psychosocial problems as well. And I think it's not easy to deal with those things, but being aware of that and not brushing them aside and ignoring them would be important also.
We have 1 minute left for one quick question by Louise. Any evidence that standing workstations reduce the recurrence of back pain?
So standing workstations, can they reduce the recurrence of back pain? I'm not aware of any evidence about that. I think it makes sense from a face validity point of view, but I'm not sure about any science behind that.
Fantastic. Well, I'd like to thank you really on behalf of the department. Outstanding talk and really learned a lot. Thank you so much for sharing that with us and for joining us here today. And everyone for joining us, have a great afternoon. Thanks, Mohan. Bye.
Okay, thanks everybody.